Thank you, Maria, for the introduction. Thank you, Oysten, for inviting me, and I will wait for a few seconds that all people who want to leave after the lecture of Dr. Rossi can go ahead. Obviously, nobody wants to leave. That's a poor decision, so I will continue. So sometimes your first impression is wrong because it looks like this. And that's what this lecture is all about, seeing things differently. And I'll show more of these kind of eye teasers to keep you awake. That's why they wrote this book, Atlas of Normal Variants That May Simulate Disease. But it's a very dangerous book. It's almost lethal. It's like a weapon, point this way. You really need instructions to use it. Because I can publish the same book with the same content, and it looks like this. Diseases that may simulate normal variants. It's the first edition. It's not for sale yet, but I can advise it to you. So you really should be very cautious by using this book. Always buy this book also. So let's go ahead and start off with the mediastinum, and we go to all kind of locations in the chest and in the abdomen, and also a short visit to the neck. So, is this normal? Well, it depends on the age. This is thymus, and in a very young infant, it's completely normal. It may be quite large, and it has very specific characteristics, like it has a weak tissue consistency, so it doesn't compress vessels at all, despite its size. It has a very specific texture. It's homogeneous, but it has quite a coarse texture in which you can recognize it. So it shows a very typical wave sign, and this wave sign, which you can see over here, and I don't have to explain why it's called the wave sign, I suppose. It's caused by the impression of the ventral ribs, in this case on the lung, but here it's on the thymus, and that is what we see on the AP view. So it's more or less the impression of the ventral ribs, and because the thymus has a soft consistency, it will show off. So that's very normal for thymus. That's the way how it's recognized. And another specific feature for the thymus is this. This is not an atelectasis of the right upper lobe. It's just thymus. And when it looks like this, it may be called the sail sign, because it looks like a sail. This is the minor fissure. Obviously, it extends a little bit in the minor fissure, and it looks like this. And that's quite normal. And what do you think about the trachea? Is that normal? Because it looks like this, very silly. Is it still an atelectasis? This is not a child, also with the sail sign, and also this kinking. And when this is acute and to the right, then it may be considered normal. And it's caused because of crying. When the child relaxes, this will be straight. And when it's concave or convex like this, and it is to the left, then it should be pathological. It cannot go to the left because the aorta is over here. So when it kinks, because of crying, it will kink to the right. So that's also normal. So this is a more difficult case, which in the end turned out to be thymus also. But this is an older child, 10-year-old child, who had a low-grade fever and a cough. And the cough was caused by this, some kind of bronchitis-like disease. But this is much more interesting because this shouldn't be there. And where is it exactly? We don't see any overlay with the caval vein, so obviously this part is in the anterior mediastinum, but it also extends above the sternum. And above the sternum, there's no anterior mediastinum, so it also should be in the posterior or middle mediastinum. So this deserves further examination. First of all, ultrasonography, of course, and we can see the coarse texture of the deep structure, but also the ventral structure has the same coarse texture. So on MR, this looks the same as this looks the same as this looks the same, this looks the same, and if we look at the T2, the anterior part, this is how thymus looks like, even at this age. And the posterior mass has the same characteristics, only this is ectopic thymic tissue. because it has the same texture, it has the same MR characteristics, and it's known that it can be there. It can be almost anywhere, that thymus. So we didn't do anything, we just waited. She turned out to have pertussis that was causing her complaints. This was 1 month later, exactly the same, and she's still doing well, and after years it's slowly becoming smaller and smaller, like normal thymic tissue will do. So these are different manifestations of thymus. Let's make a short visit to the neck, and this can be a tree or a person with a skin disease, whatever you want. So this is a 3-year-old boy who had enlarged cervical lymph nodes, and of course the parents were concerned. But performing ultrasonography at this age, these are completely normal reactive lymph nodes. If we see nodes like this in an adult, it's pathological. We think of Hodgkin's disease or other lymphatic diseases, but in childhood, especially at this age, it's completely normal. The way it looks, the size, this is normal. So the parents were relieved. However, when we took a close look at the rest of the neck, which of course we do, then we saw something like this, and we saw something like this. So there was a mass caudally of the right thyroid lobe and a thyroid nodule in the left thyroid lobe. So again, the parents were concerned. But having a close look, we see that this nodule on the right side has a very coarse texture, just like thymus does. Also, the lesion in the thyroid has the same coarse texture like the thymus does. And that made a diagnosis, and this is very well known. This is ectopic thymic tissue that can be in the neck, but it also that even can be inside of the thyroid gland. So again, the parents were relieved. So normal variants that may simulate disease. Is this normal thymus? Look at the age. It's an 11-year-old boy. Look at the compression of the trachea. Look at the ultrasonography. It's not homogeneous. It doesn't have a coarse texture. It's very irregular and signs of inflammation. So no, this is not thymus. This is a T-cell lymphoma. So this might be called a disease that simulates a normal variant. So you always should think when you see something like this. So is this a normal thymus? I think so, because somewhere I see the wave sign. It's a very young child. So yes, this is thymus. Is this normal thymus? It's at the same position. I don't see the wave sign. It's an older sign. And if you have a very close look on the left side, behind the heart or behind the mass or inside the mass, you can see some coarse calcifications. So in this case, of course, we proceed to further investigation, for instance, ultrasonography, and then we see a lesion like this, consisting of different tissue components, and this turned out to be a mature teratoma. So this was a disease simulating a normal variant. So no, this was not a normal thymus. So you should always play between normal variant and pathology. Again, a sale sign on the left side. It also exists on the left side. This is our famous kinking again. So this is completely normal. And sometimes we see something like this in very young children. It looks like this. This is thymus. And now we see the medial side of the thymus bordered by air. And this is called the Spinnaker sail sign. And the Spinnaker sail sign is a sign of pneumomediastinum. So air within the mediastinum, like this. So it's a barotrauma, usually in intubated children. There you see the air. And this is making the border on the X-ray. And it should be like this, no air at all. So then we speak about the Spinnaker sail sign. And that's not normal thymus, that's pathology. So in one of the last examples of the thymus, this is normal thymus. This is thymic tissue in the neck, and it contains a cyst. So this is an ectopic thymic cysts. These also exist. Let's go on to the real mediastinum. One of the things we all know, I think, and if you don't know it, you should know, it's the aberrant right subclavian artery. It simulates a double aorta, but it's not compressing on this side. It always has an oblique course, like this. And on the lateral film, it's on the posterior side of the esophagus, not on the ventral side, because then we're speaking of, for instance, a pulmonary sling, but it's on the dorsal side, a course like that, then it's just an aberrant right subclavian artery, which is a normal variant and which should be left alone in most cases. There it is, and there it is. And there's moving behind the esophagus and, of course, behind the trachea, originating as the last vessel from the aortic arch. And this is at a faster rate. It exists, it's a normal variant, it's not a pathological ring. So, let's go down to the ribs. And let's go down to these boys, because this is the most difficult diagnosis, because there is no bench. And it's very difficult to detect something that isn't there. So that was the eye teaser for the ribs, but I'll show you things which are there. This is a 7-year-old boy who has a prominence at the right chest. Well, I think you say that's obvious because he has a bifid rib over here. However, the prominence is here. So what's happening here? We need ultrasonography, MR or CT, and of course we perform ultrasonography because the variant we see over here, of course, is also over here, but we cannot see it. These are normal variants of the ribs. So if we have a look with ultrasonography and we start at the sternum and then go in that direction, we see something like this. This is one rib which is going in a very eccentric way, making the prominence, then goes back and then fuses with the other one, and then we see the osseous structure we saw on the image on the chest film. So these are normal variants, but also of the cartilage. For instance, look at this 7-year-old boy who has a prominence at the right chest. I don't see any abnormalities on the ribs, but there still was a very clear prominence. So again, we use sonography, and then we can see that the normal variant is in the cartilaginous part of the ribs, which is clearly bent instead of the normal left side. So these are normal variants that cannot be seen on conventional X-rays, but are present and can be visualized, for instance, by ultrasonography. This is an all-time favorite, and many of you know it, but it is a normal variant, and it should be mentioned in this 13-year-old boy with preoperative radiograph. And as you can see, there is an unsharp right heart border and some crowding of the vessels over there. Well, that might be a middle lobe pneumonia or a middle lobe tumor, for instance, whatever. But look at the lateral film, it's just the pectus excavatum. And some people have it. We can consider it in some people as a normal variant, and it may simulate middle lobe disease. So let's have a look at a 10-year-old girl, and look at the neck. It's a post-operative radiograph to explain these clips. But what's wrong in the neck? I hope it's visible. Oh yes, you can see it over there. Is the pneumomediastinum. 1 month later, it was gone. And this is an abnormality, a normal variant we often see in girls and not so much in boys. At least not nowadays. In the 60s, we did see it. Because it's overprojection of hair. It can look like subcutaneous emphysema or pneumomediastinum, but when it's drawn away, it's completely normal. And we have different hairstyles like this. This might be a Chinese girl, And this might be an Afro-American girl or an African girl with Rasta hair. You have different hairstyles, and you should be familiar of that before accusing those children of severe pathology. This is also a nice one. At a glance, it looks normal, but look at the annotation. This is a mistake often made by radiographers. This is the L, and it should be there, but the L is okay. But they flipped the image because they know the heart should be on the left side, and they even ignore their own L placement. So this is a situs inversus, and it's more than that. So it's not actually a normal variant. It can be a normal variant if the rest is normal, but usually there are some other problems. And as you can see, there is some intermediate position of the liver. And if we have a look at the spleen, this polysplenia, many splenic lobules, and we can also see it on ultrasonography. And in this case, it was the polysplenia syndrome, which consists, of course, of polysplenia, an absent intrahepatic inferior caval vein, which is just visible here, an intermediate position of the liver, left isomerism of the lungs, and congenital heart defects, as our child had. So let's move down to the abdomen. And of course, you as a radiologist have seen the abnormality, talking about inversion. First of all, many, if not any, adult radiologists don't know what this is. Pediatric radiologists know. But when my residents see it for the first time, they have all kind of fantasies about the silly structure above the kidney, which is a completely normal adrenal gland. It's huge in infants. I don't know why it is so huge. It doesn't disappear, of course, but it shrinks within a few months until it's almost invisible on ultrasonography. And it even can we even can have hypertrophy. These legs of the adrenal glands should be straight, and once they look like cerebral tissue, then it's too large. And in this case, then it's adrenal hypertrophy, and then it's not normal anymore. So be aware of the normal adrenal gland. And moving down to the kidneys, there it is. This is also a peculiar aspect of the kidneys in children. The medulla is quite hypoechoic. For people who are not familiar with it, it can be mistaken for hydronephrosis. So one should be aware of that. This is normal medulla, normal pyramids, and it can be so black in children. It's completely normal. Of course, we all know the dromedary hump, like this in the left kidney, sometimes a little bit on the right kidney. And this is a mistake you all are going to make, because I have made it several times. If we look at these two kidneys, and we look at these lower poles, which look quite normal, this patient still can have a horseshoe kidney. And I have missed several horseshoe kidneys in my career because they can look so completely normal. You really have to look for the parenchymal bar. And yeah, once you look at that from the ventral side, it's quite easy. This is duodenum, which is normal. Then we go down. And there is it. You can't miss it. But you should be aware of the fact you can't find, sometimes you can find it by chance, but you also can miss it very, very easily, horseshoe kidneys, although it looks so obvious. Another thing you should realize once performing ultrasonography in children, that it's completely normal that the cortex is hyperechoic to the liver in this age, 3 to 6 months. After that, it should be, as in adults, always more dark, hypoechoic to the liver, unless there is, of course, liver disease. But this is completely normal in young children. This is also completely normal in young children. And then I talk to children from between 0 and 7 days. These very white pyramids, over here and over here and over here and over here. And it will disappear in 1 week. And it probably is some precipitation of urate or protein, and that's why it sometimes is called TEM-Horsfall proteinuria of the newborn. It's not exactly know why it happens, but it does happen. And if you see it, don't accuse the child of medullary nephrocalcinosis or stones. Just look at the child after 1 or 2 weeks, and probably it has disappeared. These are physiological neonatal hyperechoic pyramids, quite normal. As normal as the fetal lobulation. And these lobulations are always in between the pyramids. These are not scars, no infarcts, it's completely normal. You can see it on ultrasonography, you can see it on CT, and of course on this drawing. Persistent fetal lobulation. It's quite common, as we can see it over here also. But this is a patient who has specific reflections over here. And that's also quite normal in children because we can visualize the kidneys that well that we can even see the arcuate vessels which run like this. And when they run in this direction, they have a 90-degree angle with the vessels. So they reflect to the best advantage. And that's why you can see them, because of the geometry of these vessels. And there they are. These are not small calcifications, completely normal vessel wall reflections. Of course, we know the duplicated collecting system is boring. What's not boring, a newborn baby girl has a huge uterus. You should know that. It's not a tumor, it's not an ectopic kidney, it's not a fluid-filled bowel loop. No, it's the uterus. It's even larger than the rectum. And it will stay like this for several weeks or months, and all by hormonal stimulation of the mother's estrogen. It's also completely normal, a large uterus in neonates. And to end with, the intestines. Not this. Is this normal? Premature neonate, and just an X-ray for the position of the venous umbilical line, which is, of course, too high. It's completely normal. Why? Because 6 hours later, it looks like this. Because at this age, he's only 6 hours old, and the air hasn't reached the other bowel loops yet. So always take into consideration the age of the child, even in hours. There's not a big tumor over here, it's completely normal, and it's normal when he's 12 hours of age. This is an often found coincidental finding during abdominal ultrasound, in this case for follow-up of a urinary tract infection. And since we are looking at the bowel loops more often and often, we see this more often, and it's just a normal variant. It's an interception, yes. And should we treat it? No. Because look at this interception. It's moving. The intercepted loop is moving within the interceptum. These children do not have pain. Again, it's a coincidental finding. These are benign small bowel interceptions who have a small diameter, 1.4 centimeters, a short length. The peristalsis continues, they contain no lymph nodes, and they don't need reduction. They reduce themselves, often during the investigation. And look at this. Is this a tumor at the side of the stomach? Because this is the spleen. And what's this? This is a stomach filled with inspissated milk in a normal child. It looks like this. This is a filled stomach after a feeding, simulating an adrenal neuroblastoma. And this is an adrenal neuroblastoma simulating the stomach. So, normal variant that simulates disease, a disease that may simulate a normal variant. Reactive mesenteric lymph nodes, as in the neck, completely normal at a certain age. They present in virtually all children. They may vary from 1 to 10 millimeters in short axis, and 50% of these nodes are larger than 5 millimeters. They should be left alone. There's no pathology. And this is my last case, peculiar case, and always think of, well, something like this. This was a premature neonate who has obvious some bowel problems, but my eye was attracted to this structure. And I really couldn't find out what it was. My knowledge wasn't good enough. Was it meconium peritonitis? Was this some kind of a teratoma-like thing? And then I went to see the patient to perform ultrasonography, but that wasn't necessary anymore because it was just a dried umbilical cord. Children at the age from 1 to 2 weeks have something on their belly, and that's the umbilical cord, and it can give nasty artifacts. So to conclude, always remember, and I haven't shown them all, there are normal variants that may simulate disease, but there are also diseases that simulate normal variants, and therefore a profound knowledge of normal variants is necessary, combined with clinical information, to make the proper diagnosis. So I thank you for your attention, and if there are no questions, you can always ask what this is supposed to be. Thank you.